Okay, so welcome everybody who's here with us today and everyone who will be watching this video in the future. We are the Alzheimer's Society here on Perth, and we are happy today to have Dr. George Kim here to talk to us about dementia and medical aid in dying. I am Jeanette Sears. My coworker Christy Bannerman is here with me. Um, we are the public education coordinators at the Alzheimer's Society here on Perth. This winter in Huron, Perth, we've been really diving into some important topics. In January, our local geriatrician, Dr. Peel, joined us to talk about end of life planning. And she really emphasized the importance of looking forward. And she encouraged us to remind us that, healthy aging really needs to include being prepared for those future health decisions. Earlier this month, the McKay Center for Seniors and Huron Hospice also co-hosted a speaker from Hospice Palliative Care Ontario, and she spoke more broadly about MAiD in Ontario, and she brought forward the idea of planning for a peaceful death. And for everyone, that definition of a peaceful death is unique and, again, important for us to consider. So for today's presentation, I am so happy to introduce Dr. George Kim. Dr. Kim is a practicing family physician at the Byron Family Medical Center in London, Ontario. He has a special interest in palliative care and medical aid in dying. He supports palliative care services in London and in Middlesex County through his community work, hospice work, and inpatient hospital care. He's been a member of the local MAiD team since 2016. And Dr. Kim also holds a number of administrative roles through his hospital work and through his university affiliation. Dr. Kim spends his free time with his family as they travel, play baseball, and discover new baking adventures. I think that is wonderful. Dr. Kim is going to help us today to understand the complexities around the topic of dementia and medical aid in dying and shed light on some of the updates. So we welcome Dr. Kim.
Jeanette, thank you so much. Thanks to you and Christy for this invitation. Jeanette, thank you for that very warm introduction. It's always weird when you hear someone else talk about you. So, but that was very kind of you. And for everyone, for setting aside some time on today to join us on this call today. I'm based out of London currently, and if anyone's in London with me and you're looking at your window and you're wondering, yes, no, it's supposed to be spring, it's snowing where I'm at. So I'm hoping all of you, the rest of you that aren't in London, are joining us from somewhere where it's not snowing. And so we will live vicariously through all of you, because hopefully where you are, it's warm and beautiful and sunny. But if not, hopefully over this next 90 minutes together, we are going to shed a little bit of light. Jen, I love the way you said shed light, because I think that conversations around death, dying, dignity at end, can be taboo in lots of cultures. And so it is a conversation that is often in the dark, both emotionally and existentially. Add in the complexities of caring for someone who has cognitive impairment or who is different than they were before, and the struggles that we as caregivers and family members will often live with as we try to understand best for the people we care for, both again, personally and professionally. So looking forward to our time together. I do not come to this call as an expert. I come to this call as a provider that has had almost 20 years of experience as a family doctor and as a palliative care provider and as a teacher, being in spaces with learners, patients, families, and learning as much from them as they tell me they learn from me. And then putting that all together into a presentation and just being present so that I can help facilitate a conversation. I hope, though this is Zoom, It does allow many from far places to participate, but clearly sort of the intimate nature of wanting to pose a question gets a little complex and complicated. And so we'll encourage people to think about typing things into the chat. There's lots of opportunity for Q&A, but the actual slide presentation is relatively short. And we'll see what questions and where you take us. The other commitment I'll make to people who are with us today, okay, if this is the first time we're meeting, great. If you've heard me before because you've been at other sessions with me or have had the privilege of working with you, thanks for joining. Welcome back. If at the end of it you're like, oh, I wonder if he might come and chat with my group here, please. My contact information is available through both Jeanette and Christy. This is how I came here. Jeanette was at a session I gave a year ago and wondered if I might come and speak with her people. And so this is the best way we can shed light, is just creating pathways of conversation, opportunities to be open, honest, vulnerable, bold, questioning. There is no wrong question and there's no unsafe question. I just don't know that I'm necessarily the one that's going to have to give you the answer, but we'll see where we go. Without further ado, we'll jump right into the presentation. So again, I have a small little slide presentation that I want to share. So thumbs up that it's visible. Perfect. Move this over here. So this is our talk. This is who I am. Again, family doc for 20 years. Again, I cut my teeth as a family doctor actually in West Lorne, a small little hamlet just south of Chatham. So if anyone is joining us from the West Elgin, Chatham, Kent area, hello to my people. And also previously I held an administrative role at the medical school, and so I would travel through the region quite often, and so have very good, strong memories and relationships with many people in Huron, Perth, our hosts for today's session today. So let's see where we go. So a big thank you. The Canadian Association of MAiD Assessors and Providers, so the acronym is KMAP, is a national organization, a nonprofit, grassroots started by providers. In the early days when the legislation permitted providers to have conversations with their patients around dignified passing and dying with dignity, all of a sudden, many of us felt like we were sitting in a vacuum. We actually didn't know who we could talk to, phone a friend, so to speak. And so KMAP assembled around this notion of providing a forum initially where we could connect asynchronously to just have conversations, ask hard questions, not feel so alone. Fast forward 8 years, KMAP is now a internationally recognized body of experts that continue to study and provide support. And so they have a number of working papers and documents that have been generated over the years to help guide clinicians, providers, clinical teams, as well as families and patients through what is still a most difficult conversation around asking for help to die with dignity and peace for lots of folks. And so KMAP continues to contribute. And so for people who are clinical on this call, if you've never heard of KMAP, please do Google it. If you are a provider and you're wondering, hey, Dr. Kim, do I participate? Is this something I'd love to get more information or some mentorship? KMAP is available to my families, to the patients, to the folks who support patients and families, lots of family-facing and patient-facing documents and information available on KMAP. MAPSO is the MAiD Assessors and Providers of Southwestern Ontario. So MAPSO was our little group from which KMAP sprung as it connected nationally. And so MAPSO is for Southwestern Ontario. Again, assessors and providers, and we meet on a pretty regular basis. Grateful to my colleagues. Again, this work, I come standing on the shoulders of giants. It's a metaphor that's often used, but it's really, really powerful and fitting here. The work that I have the privilege of doing on a regular basis can only be done because I have learned from many, and I stand among giants within the fields of elder care, palliative care, nursing, rehabilitative sciences and medicine. Many of my greatest teachers have been PSWs at the bedside doing the hard work, and families. And so to all of them, for helping me be the teacher and provider I am today, and to the Geriatric Refresher Day team. So a special thank you to them. So a version of this talk we did at Geriatric Refresher Day last year, and then from that, a number of opportunities have sprung up where I've had invitations to come and do sessions like this, and so grateful to my GRD team, and then of course my friends at the Alzheimer Society here on Perth for hosting us today. So. Uh, that is the slide that is the longest. I promise. Disclosure one, I do receive small stipends affiliated with my work. So CAMAP gives me a small stipend because I'm an education content developer. I have an affiliation with both London Health Sciences Centre and St. Joe's Healthcare, and then Ontario Health at Home, which is the modern day version of the LIN, which was the CCAC. Again, for those that have been in the business as long as I have, home care has changed its name quite often. So I do get a stipend for the work that I do through Ontario Health at Home. Disclosure number two. And so again, if we didn't have so many people, I'd say, hey, can anyone tell me where this is? And see if anyone was able to recognize this sunset and this view. So this view is just from the coast, just north of Grand Bend. I like this picture, especially considering the work that we do in caring for people where we don't always know if there's going to be a tomorrow. And if we have the privilege of being in someone's space as the sun sets on their final day. And for those of us that have the privilege of having an impact on what someone's final sunset might look like, what their experience might be, I just want us to remember all that we learn, and that our calling, for those of us that are in a professional space for this, our calling is to know that when that sun sets, the memory imparted for those that are family and friends of that loved one is both that beauty, peacefulness, and serenity at a time of utmost grief and sadness, that we help them get it right. And so when I do this work, I often think, how am I going to help this family and this loved one appreciate their final sunset? So I think of this quite often. At the end of it, again, I am not the expert for every patient's experience, but hold a privilege that I have a bit of knowledge and experience that allows me to be open to the hard questions and help facilitate a discovery of answers. Often the answer is there. How to proceed is kind of enmeshed and immune and within the lived experience of that family, of that patient, of the care that's occurred from all members of the care team. And so may that be one take-home message today, that everyone matters, everyone's opinion's important. And for those of you that have the privilege of maybe holding a more senior or coordinating position on care teams, that you're sort of endowed with the power, skill, knowledge, skills, and attitude to help facilitate that conversation so that all the voices are known and heard, and then ultimately the patient's wishes are respected and met. So for those that might not know a lot about sort of medical aid in dying, or if the information you're getting is from online, or maybe you've already well read, and people on the call are already members of KMAP and MAPSO, maybe you've had someone who's had a MAiD provision, so medical aid in dying, often referred to as MAiD. The actual procedure or act of receiving the medication we call a provision. And so if you've had that experience and you already have some knowledge, if you haven't and you've come to this talk today because you're like, hey, Dr. Kim, I just want to know. We'll start with some simples. So medical aid in dying is the administration by a physician or a nurse practitioner of a substance to a person at their request that causes their death, or the provision of medication of which the patient may self-administer to result in their own death. In Canada currently, the administration of the medication or the provision of the medication to be administered by the patient can only be done by a nurse or a nurse practitioner or an MD in the current setup. This does not preclude involvement of everyone else in the CARE Act. So there's the act and the provision of the medication, but then there's the act of the care overall. And that team is intentionally as big as the patient needs. So everyone's voice matters there. a small little overview if you're like, well, I've heard that MAiD's available elsewhere. It's called lots of things in different places. So several countries all around the world, a medical aid in dying is legal, decriminalized. Again, the language sort of reflects the local jurisprudence. So Austria, Belgium, Germany, Italy, Luxembourg, Netherlands, Portugal, Spain, Switzerland. So a lot of the European countries, a handful of US states. Again, considering the change in the US political climate, we don't know if this is going to stay, whether some of local state health decisions are going to be reversed sort of centrally and federally. But for now, this is current state affairs. So I've been a doctor a long time, and I entered palliative care early on in my medical career. Actually, I was a medical student when I had my first experience with a patient who was dying, and the powerful draw that I had in connecting with family and helping them through a very difficult time. And so my interest around aid in dying and probably collectively in the Canadian conscience for people who are aware of dying with dignity, the story of Sue Rodriguez probably is the first story that sits with all of us. And so if, depending on your birth year um, and what generation you're from, the name Sue Rodriguez will ring. It does not ring hollow. Her story was pretty public for the longest time, and that was her choice. She wanted people to know, and so that's probably the start for lots of people in the clinical space and in the caring space of where aid and dying conversation started. And so, again, Sue Rodriguez's journey through the judicial system was not successful for her. The final Supreme Court decision was actually very close. The final decision that did not support Sue Rodriguez was 5-4 against. These two lovely souls, so Kay Carter and Gloria Taylor, both West Coasters, they picked up the mantle. And so the Carter decision, named for Kay Carter, was the ruling from the Supreme Court that supported the BC Civil Liberties Association's claim that the Constitution, the legislation preventing a person from choosing their right to die was not constitutional, forcing the government to go back and develop legislation. And so these two individuals and their families are often cited as the leaders on this change. Jean Chouchon and Nicole Gladue, two Quebecois individuals who subsequently picked up the mantle when the preliminary description of the legislation and the implementation of aid in dying um, resulted in certain patient groups being invisible still. And in the early days following the passing of the legislation in 2016, many providers struggled with how do you translate legal decisions into medical practice and to through a patient-centered lens. And so both Monsieur Chouchon and Madame Gladue were brave to say, look, this is what we're experiencing. And providers are telling us that we're not eligible for aid in dying because our suffering was not measurable with the tools that the medical team were using at the time. And so they took to Quebec Superior Court a challenge around the reasonable foreseeable nature of death not being a mission critical element to the original legislation. So following their work through the Quebec judicial system, changes were made to the legislation, allowing for what we now call a track 2 consideration. So in medical aid in dying, we have what's called a track 1 provision or a track 2 provision, which we'll talk about in the next slide. But that was the Gladue-Chouchon decision. Audrey Parker, again, I share people's names and pictures because their families have given us permission. Because these really incredibly brave souls stepped forward and made their stories public because they wanted the public to understand that despite the work that had been done, there were still gaps in the execution, operationalization, use the term the delivery of that which many beforehand had fought so hard for. And so Ms. Parker from the East Coast unfortunately had the diagnosis of stage 4 breast cancer. Their care team did very much say to them that, at some point you may lose the ability to be aware of the world. And knowing that they had been approved for aid in dying, was quite worried that they would lose capacity to be able to say at the time when they wanted to proceed with the provision that they were going to be, quote unquote, of sound mind. And so Audrey Parker, through her brave story, forced an additional change to the legislation, protecting an individual who has been approved for aid in dying to still be able to go forth with the provision at a time, even if they lost their capacity. And so, again, those provisions and explanations have been subsequently outlined in the legislation. So for those that are more word oriented in the history timeline, so 2014 actually, so 2016 is when the Canadian government passed through Royal Assent Bill C-14, decriminalizing medical aid in dying. The story actually predates this, as has many changes within the aid in dying narrative been prompted. These changes have actually come from our colleagues in Quebec. So actually, the story starts in 2010 when the Right to Die movement gained a lot of momentum in Quebec. And for the first time in a long time in Quebec political history, multiple parties agreed to study the question around the legal right to die, resulting in 2014 Quebec's Bill 52, an act respecting end-of-life care, which permitted providers in the province of Quebec to administer to a patient a medication cocktail that would result in their passing, which provided the base from which the BC Civil Liberties Group took to the Supreme Court the national challenge that resulted in the 2016. And so there are specific criteria in the original legislation. Patients need to have a reasonably foreseeable natural death. Again, a legal definition, not something that, again, for people who are medical on the call, this isn't language we use. We don't say we think it's reasonably foreseeable natural death. And so, but that was the language that the legal scholars put into the legislation. Intolerable suffering had to be noted. You had to have a valid Ontario health card. We didn't want medical tourism, people coming to Ontario from other jurisdictions, people coming to Canada from other jurisdictions, as had been the practice prior to 2016, with people traveling to jurisdictions where aid in dying was legally permitted. You had to be over the age of 18. Again, in the contemporary framework, there is ongoing discussion and legislation, uh, cases traversing various levels of the judiciary around mature minors. Could the age be something other than 18? But for now, it's age over 18. And they must have the capacity to participate in the assessment, and at the time of provision, have the capacity to say, yes, please proceed. So because of Gladue, Truchon, Audrey Parker, and many, many other patients who were brave to share their story, they gone back to the courts. The courts responded, gave the government direction that they needed to improve on some of the preliminary language and directions. And so in 2020, Bill C7, with amendments to C14, now we have a not reasonably foreseeable natural death. So again, we as providers don't need to anticipate whether or not an individual who is suffering has a shortened lifespan, is the other way of thinking of it. And so if you do have a reasonably foreseeable natural death, without the disease that afflicts you, you would live longer than you would if you have that disease. You are track 1. If the disease you're experiencing has no impact on your prognosis and your lifespan, then you are track 2. If you're a track 1 and you've been found eligible and you have selected a date for your provision, you can sign what's called an advance request or an advanced waiver, which allows a team to still proceed with the provision, though you may have lost the capacity. So again, this is the eligibility: age over 18, OHIP, reasonably foreseeable natural death, intolerable suffering, and must retain the capacity to make healthcare decisions. So as we go through this, for those on the call who have a loved one that may have impaired cognition, major neurocognitive disorder, minor neurocognitive disorder, dementia, mild cognitive impairment, regardless of the label. They have a disease experience, a disease state, illness experience that's impacting upon their wellness. Or you're a part of a care team and you care for someone for whom um, you see that they're suffering. You care for someone who's asked and said, look, I know my rights. I want to see the MAiD doctor or the MAiD nurse practitioner or the MAiD team. These are some of the things that, as an assessor, we think about. These are the things that we are going to want to know in making our determination. Current state. So I apologize. This data is just a year out. The final data for 24 is currently sort of hot off the press, is coming off March 31st. So 24 data has yet to be circulated. So just to kind of get an idea of like, what are the numbers like? As part of the legislation, Health Canada has to annually publish data around aid and dying provincially. Coroner's offices have taken on the responsibility of publishing local data. The Office of Chief Coroner in the province of Ontario sends out quarterly data to give us an idea of, cause of death, location of MAiD provision, how many are track 1, how many are track 2, what were some of the eligibility criteria. And so I share this slide so you have a sense of, the vast majority, probably not surprisingly, the vast majority of the patients that we see is for cancer-related conditions in their request for aid in dying. And then we look through that list and you notice, okay, so cancer, we notice heart disease, we notice lung disease, and then neurodegenerative. And so probably, again, the coding is very crude. And I mean, no disrespect if there's any statisticians or epidemiologists on the call or any government people on the call. Again, the preliminary measuring sticks, this is what it is. And so most of my patients for whom I care who have dementia, mild cognitive impairment, major neurocognitive disorder, their passing, their provision would most likely be coded as neurodegenerative. Mary Wilson. Lovely Mary, diagnosed with Alzheimer's disease. So Mary's story is the one for many of us, both in palliative care and elder care, and in aid and dying work, we think about, because Mary was the one who wondered, as a patient who just has dementia, am I eligible for aid and dying? Again, for many on the call, when I say, in her story from the period of time 2013 and 2017, this is what she started to lose. It may be familiar for many. Some people on the call may know Mary's story very, very well. We wondered, advanced state of irreversible decline in capability. So the Mary of today was not the Mary of yesterday, a year ago, 5 years ago, 10 years ago, when they had children, when they first started to work. They were able to say to us, this is my choice. They understood all the options that were being told to them by their specialists, by their rehab team, by their care team. They knew if by making this decision, this is what was going to happen. Didn't like the side effects from the medications, trying to do rehab hurt lots, would lose lots of days whenever they tried to do the rehab for day one. And understood what the alternatives were. Understood that aid in dying wasn't their only choice, that there were other support facilities they may transition to. As things got harder, there were other places in the system that would be able to provide support. I think where lots of providers struggle is that when we care for patients with dementia, it hasn't become normative to sort of talk about how this story ends, because we fight so hard to just want to make sure today is the best day, and that today's best day is linked to tomorrow's best day. And we string together enough best days, all of a sudden we have best weeks, and best weeks string to other best weeks. And that just continues to scale. And in that sort of fastidious commitment to holding the status quo or improvements that are incrementally based or ginormous, we sometimes don't have space to think about. In the end, how does this story end? How does the final sunset look? And so it sounds like you've had some incredible people already share space with you and talk about goals of care and planning and good palliative care. And in these spaces, I often will say, as a family doctor first, who has the privilege of doing palliative care with my patients and families, aid in dying is one tool in my palliative care toolbox that I will share. And it is not a matter of either or. This isn't a you get palliative care or you get aid in dying. I would assert and often have that aid in dying is a critical tool piece or a tool in the toolbox of dignified care that we provide for our patients, no matter where they are on their illness trajectory when they have life-limiting disease. And so I don't mean to tie all dementia stories to all life-limiting disease and then triangulate that with aid in dying. But more today's session is to bring forth that that conversation out from the darkness around if I have a loved one, if I have a patient, if I have a resident, if I have a person with cognitive impairment, and they ask of me, do I have the right to die with dignity? Do you think I could have MAiD? These are some of the things that we would think about. Again, recognizing that I'm on a call with experts far smarter than I and far more experienced than I when it comes to the everyday care and the scholarly work and the scientific research and the advancement in the support of patients with dementia. A little bit of the factoids, and so many of these numbers I've taken from the KMAP working paper on the support of patients with dementia and the journey with aid in dying. So current state in Canada, 500,000 people are estimated to have dementia. Canadian Study of Health and Aging reports the prevalence is about 2.4% in 65 to 74, up to 34.5% for people over the age of 85. And then we talk about the gray tsunami all of the time. Next 20 years, the number of people with dementia will double. More just for the science nerds on the call and the medical nerds and the elder care nerds on the call. The DSM-5 as sort of the holy text that helps us understand mental and cognitive diseases, has renamed dementia to major neurocognitive disorder. I think sort of the rebranding is important because it helps us not just continue on the same, but forces us to constantly relook at how are we doing things? How are the people we care for experiencing things? Are we getting it right? Are we getting it right? So when I get asked to come and see someone for whom aid in dementia may be the only story, or dementia is part of the story, I will wonder, is the patient in an advanced state of decline in capability? Who are they today? Who were they yesterday? Who were they last week, last month, last year? When was the last time they had a day of joy and pleasure? Does the patient have the capacity to make the decision to have MAiD? Are they with me enough today to participate in this conversation? And this is probably where a lot of people get tripped. A lot of people get tripped. I'll enter a space, and sometimes if it's in a supportive living facility, a long-term care home, retirement home, sometimes the staff will say to me, "Oh, Dr. Kim, they can't participate. They've got the dementia." And when they use an article like and it's like the dementia, it's like to really drive home the point that 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 the patient has lost something. And so I'll often respond with, "Well, how's their day today?" And that's when I hear they're having a great day. They had a good meal, maybe a social with friends or family. They seem pretty bright today. And so my job as coming to talk about MAiD isn't to find them at their best and brightest, but it's to be with them in that moment. And if they can participate, if they have the capacity to participate in the conversation today, I'll take a snapshot. They may lose the capacity later on when, again, in the province of Ontario, you need assessment by 2 people. So when the second assessor comes, they may not be capable. And so recognizing that this is an ask that they may have put onto the care team, our commitment is recognizing the fluidity uh, in capacity. And so if today's not a good day, I'll come back another day. I'll try to come back a different day of the week, different time of day. Again, for those of you that care for individuals far more often than I do, you know it. You live it every day. Sometimes it's a good day. Sometimes it's not a good day. Sometimes it's a good afternoon. Sometimes it's a good hour. And so if we see them and we can hear them, then we'll want to be there for them and understand their true wishes. And then, do I believe that their death is naturally foreseeable? If they didn't have dementia versus having dementia, what's their lifespan look like? What's their prognosis look like? And again, I didn't put the chart up because again, it's just more numbers and not medical jibber jabber. It's still really important. But we do know, depending on the type of dementia story, their lifespan, as predicted by the medical experts, is something that we want to be considerate of. There are mimics, as we know, to dementia and dementia variants. And so we want to make sure that this isn't an evolving delirium. Again, this is more of a medical perspective or depression. And that the dementia can be the sole reason for the assessment, or it can be an adjacent element to the patient's maybe major or main disease state. So when we wonder about capacity, again, hopefully for many of you on the call, this is something that I know I'm sort of preaching to the choir. You know this, again, arguably probably better than I do. But anytime we have the privilege of entering the care circle for a patient, whether as a family doctor, I see them on a regular basis, whether it's a one-time consultation I'm seeing at home, in a hospital, on consult service, in that moment, do they understand the information relevant to their condition and the recommended treatment? I'll say, Mrs. Smith, do you know what have the doctors and nurses been saying to you? And what's that mean to you? And have they outlined what your options are? And can you share with me what it means if you choose one way or the other? And if you don't choose it one way or another, what happens? And at the end of it, what do you ultimately want to do? And if they're able to do that with me, then I have a pretty good sense that, you know what, we're in a space that we're going to be able to have a good conversation, or at least a conversation that's going to reflect what it is that they wish, hope, and aspire for. We want to consider their choice, their understanding of their current state, their appreciation of what that choice is going to result in the future. And if I were to give them multiple different options, can they reason their way through it? Can they sort of do the mental gymnastics to say, yeah, if I do A, B is the natural consequence, not 2. If I pick 1, 2 is the natural consequence, not B, Z, X, D, alpha, triangle, blue. If I fill this space with 100 other experts or 100 family members, the way they explain what they just did to me, did that reflect the way that they had always lived their life? Is that the way it would be reflected by others with a similar condition? Pretty high bars, actually. Pretty high bars. We want to make sure we're not looking to trip them or trick them, but we want to be able to, in the window of time we've been privileged to have, get a sense of who they are, what they want, why do they want it, and what happens if they get it versus if they don't get it. Again, a couple of elements in recognizing that the opportunities in doing this work when we care for patients with life-limiting disease. Again, that sunset that I don't want anyone to forget too much. Is there a way that I can dust off the crystal ball and be able to say to someone, yeah, the crystal ball tells me this is how much time we got left. This is what we're looking at. And so when we think about trajectory and prediction and prognosis, these infographics, these illustrations often reflect what many of us have experienced either through our professional work or through our personal work. So again, patients with cancer kind of sort of trend along, and all of a sudden, what I'll say when I'm teaching, or I'll say sometimes with patients, is, your loved one, the wheels have just fallen off the bus, and we can't get them back on. So something abrupt has changed, and their trajectory goes down. Usually, when there's a malignancy, it's a tipping point, so to speak, and they don't come back from it. If they have an organ disease, a failing liver, failing heart, failing lungs, failing bowel, failing kidneys, they have these moments where they have a setback, but they're able to bounce back a little bit, but never back to their original, their pre-setback level. And so overall, there's always this sort of downward trajectory. And then again, when we care for patients who have a level of frailty, because dementia is part of their story. There may never be one sort of inciting event, but it's just sort of the slow progression. And when you reflect back on that, the predictability is just near impossible to say, I think this is the event, this is the moment. And then all of a sudden we're sort of here. And we've never talked about the sunset. And so ensuring that we have honest, therapeutic, wholesome, fulsome, person-centered goals of care conversations involving everyone that loves them and for whom they love just helps us as a care team stay better informed, nimble, and ready. When we do goals of care conversations and palliative care consultations and have medical aid and dying conversations, I'm very clear with my patients and families that decisions, considerations aren't etched in stone and may reflect the today. And with every subsequent visit, we just revisit to make sure we're on the right path. But sometimes, whether it's cultural or just personal reason experiences, maybe caring for others or witnessing others, there will be a general fear in kind of speaking about the end because we don't want to spook things. We don't want to manifest by saying, oh, I'm worried grandpa might die, or what's it going to look like when mom dies, or what's it going to look like when my best friend dies. We don't want to say the D word. We're a death adverse culture, generally speaking, and it comes from honest roots. But by wanting to participate in a conversation like today, hopefully we just sort of peel back the curtain a little bit and say, you know what? I'm okay saying the word. It doesn't make it happen, but it ensures that we're all kind of aware of it. And in clinical teaching circles, sometimes when we have junior trainees and they're just like, Dr. Kim, how do we know? How do we know if someone is going to die? Well, let's be fair here, and I don't mean to be tongue in cheek. We all die. Death and taxes, right? That's the things life can come in on, for sure. We all die and we got to pay our taxes. But when we're caring for someone, I'll get them to close their eyes and think, a year from now, would you be surprised if this person had passed away? Which really forces us to kind of sit in the moment with what's happened, what's happening right now, what are the things that we have to do to a person, what are the signals and metric points that this person's body is giving us through all of our measures and our expertise? What are the words coming from this person's mouth and the mouths of the people around them? And we put them all into the aggregator that is our brain. What would you think? Are they going to be with us in a year? Now, again, for the individuals who are far brighter than I, who are on this call, they'll be like, look, Dr. Kim, we know the surprise question. The research on this we know is not very good. And so I will disclose that when the original literature and the research was done about this question, there's a lot of hope and promise. It was originally tested in an ICU setting. And subsequent to that, the scientists have looked at it and said, well, maybe it's not really good there. But many of us in community-based medicine, in primary care and family medicine, in nursing circles, again, rehabilitative medicine circles, and in elder care, this question still remains quite relevant. Not as a predictive question, but just as a sobering reminder. Have we had the sunset conversation? General indicators. So again, when families are like, well, how do we know? How do we know? And so we know the disease is advancing because they're just more frail. When we do things to them, their body doesn't respond in the usual sort of physiologic manner, in the way that we might expect. If I give them an antibiotic to clear their bladder infection, it just didn't get better this time. because the parts are just worn. And so those experiences we want to be super conscientious of. And then again, if there's a specific disease that we're worried about, what are those disease numbers telling us? Other again, again, this is taped, so you'll be able to take a look at this at your own pace and speed. So I won't go through all the points, but again, as a clinical team, we have these sort of measures or metrics or monitors that we follow to wonder, how do I know that things are starting to gradually slow down? That green graph, how do we know that time is starting to come to an end? How do we know that the final sunset is upon us? When I get invited to be part of an individual's care team and the question is around aid in dying, I need to remember, is what I'm offering justifiable under the law? And based on my values, is it right for me to help? Justifiable under law, I can proceed. Not right for me to help, I'll find them someone that can do it. And say, may those two elements be reminders for all of you when you have the privilege to care for another. So I post pictures of traveling, and Jeanette referenced my traveling, and I don't want people to think that I've got all this time and money to travel. I don't. We're not a big family of travelers. We wish we could travel more, but we do remember our travels. And so, first picture, Grand Bend. Second picture isn't Ontario specific. For those that recognize the space, this is Hopewell Rocks in New Brunswick. And so it is one of my favorite places to go. Again, for people who've had the opportunity to travel to Hopewell, you know, kind of the tides, kind of within 8 hours, water at the top of the basin, within 8 hours, water is gone. That is the power of nature, and that is the beauty, simplicity and complexity all at the same time. And so you can go at one time, walk the bottom, and then 8 hours later, come back and the water's right to the top. And so a place that represents metaphorically a little bit of what we do, in so much as the certainty and the passage of time, the beauty and majesty of nature. Sometimes the powerlessness of no matter what I can do, I can't make that water go down because I want to walk the basin bottom. But with time, what I'm looking for will come. And so I hope today we've been able to just sort of scratch the surface around the conversation regarding cognitive impairment, aid in dying. I There's my email again. Jeanette and Christy will circulate that if people have questions that they don't feel comfortable sharing on the Zoom. But that is the slide deck.
Okay. Well, thank you so much, Dr. Kim, for sharing your thoughts, sharing your knowledge and your sensitivity to this whole subject. We really appreciate it. And it helps give us more of a vocabulary to begin these conversations and to ask questions. So thank you so much.